Good morning, everybody. Thanks for being here. I know the world is literally on fire today, but hopefully everybody's safe. We have a wonderful talk today that will be a welcome distraction for the next hour. So I'd like to introduce Dr. Andrew Hung. He's a surgeon scientist who specializes in robotic surgery for diseases of the kidney and prostate. His research interests include the development of artificial intelligence methods to improve surgeon skills, assessment, and training. Dr. Hung received his Bachelor of Science degree with honors from Yale University, and he completed his medical education at the Weill Medical College of Cornell University with honors in research. Dr. Hung completed his urology residency at the University of Southern California, and he stayed at USC for a fellowship in advanced laparoscopy and robotics. After spending 9 years on faculty at USC and attaining tenure, he joins the Department of Urology at Cedars-Sinai Medical Center in July 2023 as Vice Chair for Academic Development. Dr. Hung is internationally recognized as a leader in the development of innovative surgical simulation and assessment technologies. Supported by the NIH with $7 million in funding, Dr. Hung has also become a leading innovator in the development of automated performance metrics for robotic surgery. His collaboration with data scientists at Caltech has harnessed deep learning algorithms to better predict robotic surgical outcomes and automate surgeon skills assessment. Dr. Hung has produced over 200 papers on surgical assessment and training in leading journals, including Nature Biomedical Engineering, JAMA Surgery, and the Journal of Urology. He served as the first consulting editor on artificial intelligence for the British Journal of Urology International, and he currently serves on the NIH study section on image-guided interventions in surgery. So I'm happy to hand it over to Dr. Hung to hear about automation of surgical assessment with AI.
Thanks, Dr. Taylor, for the warm welcome, and really appreciate everyone being here on such a odd and fiery day. I hope, of course, everybody's doing okay at home or at work, just somewhere safe. So this is my one disclosure. Nothing that's related to the work that I will present today. And I am supported by the National Cancer Institute. We have 3 active R01s, and some of that work I will share with you today. So here's a quick overview for the next 45 minutes or so. We'll save some time in the end for questions. Very briefly, what is AI? What is surgical AI? And the bulk of the work that our team has done is in surgical assessment, and our new work is in surgeon feedback. And then finally, I'll share a few take-home points. So this is not new to everybody. I mean, in the last 4 years, the concept of AI is quite prevalent and very much in vogue. AI is the ability for a machine to independently replicate some of the intellectual processes that we typically see in human cognition. And very briefly, within AI, there's machine learning. So it's a subset of AI where algorithms can parse through data. Most importantly, they learn from the data and then apply what it's learned to make informed decisions. And then deep learning is yet a subset of machine learning where these algorithms are truly inspired by the structure of the human brain with all its interconnected neurons to make the most effective insights from what it sees in the data. What is surgical AI? It's a term that our field kind of created, but I thought I'd ask ChatGPT what is it, and it gave me a definition that it refers to the use of AI technologies in surgical procedures to assist and enhance surgeon performance. And I saw this with a sense of relief that it didn't say to replace surgeons in what we do. And there's the text form of what GPT produced on surgical AI, and this is a visual representation also from GPT of what that might look like. There's a lot of imagination here, and of course, with generative AI, who knows how realistic any of what it thinks surgical AI may be. But this gives you some flavor where it looks like there's some imaging in the background. There's certainly robotic arms. I'm glad there's still a human looks like a physician, perhaps a surgeon in somewhere in this picture of what surgical AI is. Anyhow, so for the last 10 years, my team has looked at different ways of sizing up a surgeon. And I'll take you through, in the next, several minutes, I'll take you through that journey. Before getting into the nitty-gritties of those three ways of assessing surgeon skill, I have been in practice for over 10 years now. So we have about 10 years worth of research that I'm going to share with you. And proudly, I know Dr. Taylor said $7.5 million. We just got a brand new grant that was $3.2 million. So we have over $10 million now of active NIH funding, and we're super proud of that work, of the support to get some of this work done. So let's start with kinematics. This was our very early foray into surgeon assessment. So this was a collaboration we did with Intuitive Surgical almost a decade ago now, where they had literally a black box, a data recorder that recorded surgical video during live prostatectomies, robotic prostatectomies. But synchronized with the video, we were also collecting systems data. The derivatives of this was a purely research tool at that time. I think nowadays it's become the Intuitive Hub, or I forget how they market it. I have nothing to do with, the derivatives of what that product has become, but this was purely a research tool. So I recorded surgical video, but it also tapped into the systems data of the robot, and it captured the kinematics, which is the movements of the instruments, also system events such as energy use, camera move, all that sort of thing. And it's from this raw data that we derived what we coined as automated performance metrics. These are summary measurements of, for example, velocity of the instruments, acceleration, angulation of the arms during very specific tasks during the prostatectomy, such as suturing. This was our first paper that we published in 2018 from this collaboration. It was featured here on the cover of the Journal of Urology. And this is an illustrative example of some of the data we collected. So these are representations of these are two actual surgeons performing the exact same step of the prostatectomy. It's one of the early steps where we have to drop the bladder and to access the prostate. And as you see here, the red is the tip of the right-hand instrument, the green is the left-hand instrument, and the black is the tip of the endoscope or the camera. And as you can see, these two surgeons performing the same step look completely different. The expert is a lot more focused, efficient. You see those pockets of where the instrumentation occurs it's very, in very concentric spaces, versus our novice, which was one of our junior residents performing the same procedure. So that was just a taste of some of the data that we are able to collect. And we realized very early on, this is truly before the time that deep learning, machine learning AI has become what it is today with GPT and so forth, generative AI. This was early, approximately 2016 or so now to 2018, where we realized that, at 30 hertz, meaning that in 1 second, the data is refreshed 30 times, and we are able to collect a tremendous amount of information. How do we parse through all that information, determine what's important and what's not important, and understanding the performance of surgeons? And so we went to machine learning as a natural partner to help us parse through the data, because traditional stats wouldn't do it, because there's just way too much data points. There's too many dimensions to the data. So what we did, and this was a paper we published, this was one of our early papers, actually it was one of the first papers that we published on the concept of taking data from the operating room, so these automated performance metrics, and using AI or machine learning to process it. So this is supervised learning, meaning that for our input data, which was all of these metrics, for each case, of the prostatectomy, we tagged it with a clinical outcome. And that clinical outcome could have been anything. But early on, we had very little outcomes data. One thing we had was, as patients were being discharged, as soon as they were discharged, we had their hospital length of stay after surgery. And so it was usually 1 or 2 days, which we labeled as expected length of stay, or more than 2 days. And if you trained a model with, we trained it with about 70 odd cases, again, with this set of automated performance metrics and this label, it was a binary label. Now we have a trained model, and you have a brand new case, just performed it in the operating room. You derive these automated performance metrics, a set of metrics, we feed it into the model, and we wanted to predict the hospital length of stay. And to our surprise, and to our pleasant surprise, this model was accurate to about 80%, whether or not these new cases that the model had not seen before, these patients were going to be in the hospital for 1 or 2 days, which was our expected length of stay, or longer than that. So that gave us a lot of confidence that, hey, we may be onto something, that, machine learning may be an option. And very briefly, these metrics, or the concept of these metrics, we then published in the Journal of Urology 4 times, and each of those 4 times they were featured on the cover of the journal, just, I think, simply because it was such a interesting, intriguing concept, very novel, and no one's really ever seen that before. Okay, so, but then I think the glory days of APMs, or these automated performance metrics, kind of died, and I think I may have directly brought it to its death. And being overly dramatic here, but one of my frustrations with these metrics was that while it had a very good sense of what the instruments were doing, it didn't have a very good sense of what was happening to the tissue. So it's great that we have these hands, or these instruments, moving in 3D space, but what's actually happening to the tissue? And that's really the crux of how a surgeon operates, is how he or she is engaging with the tissue. So we came up with this concept that, hey, we need to do some technical skills assessment, and I'll give you a sense of what that means. So this is another paper from our group, a subsequent paper from our group, that illustrates this point of using surgeon skill metrics to predict an outcome. And we got more ambitious. Instead of looking at a hospital length of stay, we looked at urinary continence recovery, which is one of the main outcomes after prostate surgery. Most patients after this operation, at least traditionally, have leaked urine for several weeks to months, to even sometimes permanently. And we had a good hunch that surgeon skill, and certainly the experience of the surgeon, made a difference in this regard. Okay, so for the outcomes of the robot-assisted radical prostatectomy, we know that there are patient factors and there are surgeon factors that contribute to how a patient may do. And we focused again on this urinary continence recovery part, because we thought that while there is some patient factors that may influence it, that certainly there are surgeon factors as well. Okay, so again, the surgeon factors that we looked at, we did include these automated performance metrics that I just described in the prior slide. But the new component to it was technical skills. And this is an example of suturing technical skills, but you can imagine for tissue dissection, there is a parallel set of assessments that one can be done. But this is just to give you an example of technical skills we looked at. For suturing, how does a surgeon hold the needle? How does the needle enter the tissue, drive into the tissue? How do the surgeons place their sutures? How well does the tissue approximate, and then knot tying at the end? And, we had by this time worked on those automated performance metrics, or kinematic data, for many years. And no matter what we did to refine the process there, to train models to predict any sort of outcome, clinical outcome, we always hit a ceiling of an AUC in the 60s. And AUC is one of the performance indicators or metrics for how well the models perform in predicting a given outcome. So certainly for predicting urinary continence recovery, which is, again, several weeks to months after surgery, certainly in this situation, these metrics, the APMs, or kinematic data, hit a wall of in the 60s. But we saw that when you add those technical skills, again, how the surgeon engages with not only a needle, but also tissue to reapproximate tissue in the reconstructive step of the prostatectomy, we're now able to predict this urinary continence recovery with an AUC in the 70s. And if you added everything that we had available to us, including the patient factors, we were able to get that AUC into the 80s, which was fantastic. And for those who are not as familiar with machine learning, there's two major functions that you can do with machine learning. One is to predict the outcome, which we just showed you data on. Excuse me. But the other is to actually do what we call feature ranking, which is identifying of all the data points available to the model to correctly predict the outcome, which were the most helpful. And what we found was, again, to predict urinary continence recovery, of the top 15 to 20 features that were available to the model, age was the only patient factor that lit up. And interesting enough, excuse me, if you look at the top 5, 3 of the top 5 were metrics of surgeon skill or technical skill, as opposed to the kinematic data. So this really gave us a clue. This was a very influential paper or project for us, because it gave us a sense that technical skill, we were onto something there with technical skill, and this was certainly worth more investment, that this was somehow capturing the true performance of a surgeon, and let's spend more time in this space. Okay, so that led us to my very first R01 grant through the NIH, where we proposed automating skills assessment. Okay, so technical skills assessment for suturing utilizing deep learning models. And this was a collaborative across 5 different sites. We had Dr. Anima Anand-Kumar, who is a world-renowned AI scientist, as partners. And so this was our vision for this particular grant. We're in year 4, actually entering year 5 of this 5-year study. But this was our original vision. We wanted to take surgical videos. This could be live video or from VR of suturing. We wanted to feed it and train a deep learning model to produce a very granular report card of how a surgeon is suturing. And you'll notice that it goes from needle handling to needle, how does the needle enter the tissue, pushing that needle through the tissue, pulling it out on the other end, how the sutures were placed, and how does the tissue come together. So in very granular detail. And this was intentional because deep learning models are otherwise very opaque. They don't give you a lot of whys and so forth. But we wanted the output to be rather granular, because the goals are, at heart, I am a surgical educator. That's my passion. And what we wanted to do was we wanted to produce a very specific report card, so that, let's say a training surgeon wanted to figure out, hey, what was going on? They had a very good place to look to see where they were doing well and where were areas that they needed more work on. But that was only the first step. The second step was, now that you have this profile for a given surgeon, we want to train yet a different model to predict patient-reported outcomes. Ultimately, what happens to the patient matters the most. It almost doesn't matter as much what this report card tells you. What does matter is what happens to the patient. And so that was the full vision of this particular grant. And we're in year 4, as I said, entering year 5. And just last year, we published 3 fantastic papers in the Nature journals. And I'm going to share that with you in the next few slides. The first was that we created the surgical AI system that, amongst many different capabilities, it was able to do skills assessment for surgeons. Secondly, because if we're in the realm of training surgeons, or perhaps one day assessing whether or not a surgeon is fit to operate, we wanted to make sure that our assessments were fair. And then also, it's not satisfactory to say that, I'm sorry, deep learning models are just an opaque, situation, and here's our verdict. So we wanted to have some clues into explainability. Okay, so this is the first of those three papers. This was published in Nature Biomedical Engineering. In fact, it was featured on its cover back when this was published. And we trained a vision transformer. That's the type of deep learning model to decode surgeon activity from surgical videos. This is a busy slide, but I'll distill it down to the most relevant points. What this model did was it was able to take surgical video, which is essentially a series of frames of footage from the endoscope, and seen its changes over time. So there are two aspects of things that we captured. One was simply the pixel color changes over time, and then so that's one piece of it. The other was grouping a lot of the changes of pixels and so forth into what we call an optical flow map. This gives you a sense of what is moving, the magnitude of its movement, the directionality of its movement. So together with those two pieces, over the course of time, we were able to provide a verdict for each and every one of those sub-skills within suturing. So for needle handling, for instance, or needle driving, each got its own verdict through this parallel pipeline that you'd see over and over and over again. Okay, so we were very pleased with its performance. We were able to get our AUCs in the mid 70s and sometimes even into the 80s in correctly predicting the skill of a surgeon by just looking at their video. However, so that was the first paper. However, if you took a deeper dive and we said, okay, so is this model performing fairly across different cohorts of surgeons? Here, the example is with novice versus expert surgeons, or less experienced versus more experienced surgeons. And we found that the model was not performing evenly. It was much more accurate with less experienced surgeons than with more experienced surgeons. Another example in our training lab where we had medical students going through suturing exercises, recording the video, plugging them into our automated pipeline to assess their skill, we found that, to our surprise, the model performed a lot more accurately with female medical students than with male medical students. And to this day, we have not figured out why that may be the case. It's not that the female medical students were rated higher than the male medical students. It was simply that the scores were more reliable compared to ground truth assessments done by our trained human annotators. But there are different ways of mitigating what we call algorithmic bias or model bias. These machine learning models may exhibit a bias, and you can mitigate these biases through different programming strategies. And in doing so, you can actually improve the performance of the model overall, which is a good thing. And I'll give you an example of how we mitigated that bias. And that really leads us into the third paper that we published in the Nature journals. And that was, if you ask a human rater to assess the quality of needle handling, that's one of the parts of suturing, right? You have to get the needle in your hand, position it in its ideal position, then you drive it in through the tissue, then you do your cinching and so forth. So if you looked at a series of 1,200 frames where suturing is occurring, you don't have to look at every single frame to assess the quality of needle handling. That's, again, how efficiently and how well a surgeon positions and repositions a needle in his or her needle graspers to then drive that needle through tissue, right? You only have to look at very specific pockets of time. So what you see here, the yellow is where the human annotators are looking to find, to see the actual needle handling activity occurring. And then they do their assessments. Now, if you asked the AI model, where are you looking when you make your assessments for needle handling? You can see that it coincides in the very beginning here and at the very end there where there actually is needle handling occurring. But unfortunately, it was also looking somewhere in the middle where there's absolutely no needle handling occurring. And we see, and And so what we did was we retrained the model and said, hey, look at where the humans are looking for needle handling. And will that focus your attention a little bit better and maybe reduce some of that noise? And maybe perhaps you'll do a better job. And in fact, the model did do a better job. When it was given the insight of not only what the human ground truth evaluations were of the quality of needle handling, but in addition to that, also were privy to the information of where the activity was or where the humans were looking at, the model performed better. And on top of that, some of the bias that I just shared with you in the prior slide also was mitigated. So it really gave us a sense of, you know, where is the model looking? That's important, but also being able to reduce some of that bias that we saw. Okay, so we've talked about kinematics, the motion tracking of instruments. We talked about technical skills. I'll share with you some of our most contemporary work with surgical gestures, and I'll explain what that means. So this is our second grant through the NIH, where we use deep learning models to assess the quality of nerve sparing during the robotic prostatectomy. I assume that nobody in this room is a urologist, so I'll explain that preserving the nerves around the prostate is one of the key steps of the operation to preserve sexual function for patients, after surgery. And traditionally, about 20 to 50% of patients recover this function. So it is something that was of not dire, but it was certainly of interest. How can we improve what has been done for over many, many decades? And we really have not been able to improve how it's been done. The key reason for that is from the time of surgery to outcome, it's easily a year later that you have a sense of whether or not patients are going to recover function. And that's been the dilemma. Okay, so first, the concept of surgical gestures. This was published first by our group in Nature Digital Medicine. And these are, so whereas the prior work was on suturing, this is on tissue dissection. This is relevant to not just prostatectomy, but really any procedure where there's tissue dissection happening, right? Just as suturing is a very commonplace activity, we intentionally chose yet the other activity, probably the more prevalent surgical activity that one performs in any given procedure, in any given specialty. So if you think of tissue dissection, and a gesture is the moment-to-moment movement one is making. So there are blunt dissection maneuvers, there are sharp dissection maneuvers, and there are perhaps some more complex maneuvers that have several motions in them, but they're in essentially one package. So here are examples of a spread. So just opening the jaws of one's scissors, that is considered one gesture. That's a spread. This is a peel or push where you're separating natural tissue planes. And this is a hook. And then for the sharp dissection gestures, you have a single cold cut. This is an energy or hot cut. And then this is burn dissect. So the tissue you saw from the prior slide where you've hooked it, now you're pulling it towards you with energy on. And then again, there's combination gestures. This is pediculae, creating a window within tissue. This is what we call two-hand spread. And finally, this is coagulate, then burn. So you're controlling something, a vessel, perhaps a small vessel, and then you're cutting in between. Okay, so now could you take a sequence of video and decode it to a sequence of surgery and effectively have that sequence become spread, spread, hook, burn, peel? Okay, busy slide here, but I'm going to take you through it. This is 22 rows, and these are 22, right? They represent 22 patients who have undergone this nerve spare step of the prostatectomy. And each cell that you see here is a different dissection gesture. And these are those gestures that I just shared with you in the prior few slides. What's common about these 22 patients is that they've all undergone the nerve spare step of the prostatectomy. And while they had sexual function prior to surgery, 1 year after surgery, they do not recover function. In contrast, these are 18 additional rows representing 18 additional patients who have, same thing, undergone the nerve spare step of the prostatectomy. These are the sequences, or these are those gestures that the surgeon took to perform that step. And these are patients who do recover function a year after surgery. Now, if you use traditional means, traditional stats and so forth, looking at the usage of certain gestures, for example, energy, which we've always thought to be a problematic or a risky maneuver during the nerve spare step, we would not be able to reliably predict the outcome, whether these were going to be recovery patients or not recovery patients 1 year after surgery. But if you plug these sequences into specialized AI models, what we call sequential models, where the model has the memory of one gesture to the next, to the next, to the next, we can now predict with a very high accuracy, now into the 80s, whether or not these patients will recover function or not. And that's truly transformative for us, because this has been a procedure that has been very elusive in terms of how we could connect the dots of what we did on the day of surgery for an outcome that is not clear until a year later. And as I mentioned earlier in the prior study, one part of machine learning is predicting an outcome. In this case, predicting an outcome of good or bad, it's almost too late, right? You've already done your deed, and whatever happens to that patient happens to that patient. And so we want to take it another step. Now, whereas the last few slides of this project are state of the art, this slide and the next are more aspirational. What we would love to do is identify in a string of gestures, right? So this is one example of one patient. We would love to identify what are the gestures that are putting that patient at a higher chance of recovery. What is protective? What are maneuvers that a surgeon is doing that will contribute to a better outcome for their patient? And conversely, this is a different patient who did not recover function. What are the gestures that are putting that patient at risk for not recovering their sexual function, for instance, at 1 year? So again, these are aspirational slides, the last one and this one. This is what we would love to do. And this, speaks to a very hot area of AI, which is what we call explainable AI, where we're not satisfied with just the predictions. We want to know, hey, what's actually going on inside? Okay, so how are we going to do that? Okay, so the last couple, everything that I've presented up to now have been published stuff. And in fact, this is not published yet. And, but this is kind of the cutting edge of our work. And I'm really excited to share this with you. And hopefully it makes some sense. So everything that you just saw on surgical gestures, we've called it Gen 1 or Generation 1 of gestures. You have this long run-on sequence of gestures. And to give you context for the nerve spare step of the prostatectomy, that is anywhere between 200 to 400 gestures, meaning that for a surgeon to complete that step, they vary between 200 to 400 individual gestures to make it happen. The problem was when we were looking at the explainability part, when we were identifying these groups of gestures that the model was identifying for as, hey, this is a risky spot, or hey, surgeon did something well here. If you looked at the video of those areas, we really could not pinpoint exactly what was going on that was so amazingly great that this was protective, or so amazingly terrible that the patient was going to have a bad outcome. And so we thought as the next steps that we would add some context to this super long, if you imagine a book with no spaces, no paragraphs, and in fact, maybe no pages, and it's just, or chapters, it's just one giant long run-on hodgepodge of letters. It would be very difficult to make sense of it all. So what we have done is we've introduced this generation 2 of gesture sequencing, where we actually can group a lot of these gestures to what's the bigger task at hand. Are they releasing these nerve bundle tissues off the prostate? Are you creating, let's say, the posterior plane between the prostate and the rectum? What are you trying to do here? Okay. And then that's part of Gen 2. The other part of Gen 2 is anatomical. Where is this happening? Because we know that, at least for nerve sparing, those nerves are distributed differently, whether you're at the base of the prostate, at the tip of the prostate, on the lateral sides, on the posterior plane where there's almost no nerves to be seen. So that may or probably matter, okay? And in fact, we found that, if you took only Gen 1, we were able to perform with an AUC in the mid 70s. And by adding that extra information about these functional units, grouping the gestures into what they're trying to do as a bigger task within the nerve sparer step and anatomic location of these gestures, we were able to get the performance up even more. So we're really pushing the cutting edge because we are our own, in some ways, our own indicator of success, and we have to kind of beat out what we have already published on, and so that's the work that we're doing. Now, the further part to all this is explainable part, and that really is work in progress at the moment. Okay. I have a few more minutes before questions, so I'm going to hit on our last piece, and it speaks to our brand new grant that we were just awarded, a $3.2 million grant we were just awarded a month ago. And so whereas the last 10 years of our work has been on the assessment of surgeon performance, right? That 360 assessment that I shared with you, those three different ways that we've been looking at surgeon performance. We thought it would be timely to start thinking about feedback. How do you deliver that assessment back to the surgeon? We have not perfected the assessment piece by far. I mean, that's going to be ongoing work in progress for many, many years to come. But we thought it'd be a good time to start thinking about that delivery mechanism of how we send the data back to the surgeon so they can actually improve their performance and therefore hopefully improve outcomes. Okay, so that leads to our third active grant, and it's called Assessing, Optimizing, and Delivering Surgical Feedback with AI for Urological Procedures. For this audience, I want to encourage you to think about this as this is not a urological problem. This is all of surgery, like a big tent surgery problem of how do we optimize the training of our trainees in the operating room. Live surgical feedback is such a critical part, as you know, of how we train our future surgeons. So again, this is a collaborative project. The preliminary work for this was we recorded 30 teaching cases. These are all robotic cases, but actually they were a mismatch of many different kind of procedures: nephrectomy, prostatectomy, pyeloplasty, a bunch of reconstructive procedures. So it really does not have to be urological. We published this in JAMA Network Open, I think last year or the year before. And from there, we also recorded the audio, the teaching between the trainer, which is the faculty, and the trainee, mostly residents, but sometimes also fellows. And we identified 3,700 lines of feedback. And each line of feedback had three pieces to it. There was a trigger. What was, what triggered the feedback? It could have been the trainee did something wrong. They didn't do something they were supposed to do, or they simply asked a question. There was the feedback itself, and I'll get into some more detail about that. And then there was an outcome or some response to that feedback. Okay, so this is the more granular version of what I just showed you. Again, the trainee could have made a mistake. They could have not done something they were supposed to do. They could have just received a warning because they were doing some risky behavior that wasn't explicitly wrong, so forth. And the feedback itself could have been about anatomy. It could have been about, hey, what's the next step of the operation? It could be technical. Hey, you're not turning your wrist enough as you're driving that needle into tissue. And then there could also be what we call bells and whistles. For example, was the feedback laced with some praise or some criticism or even a visual aid? And then finally, what was the response? Did the trainee change their behavior, which is the ideal outcome, or did they verbally acknowledge and said, okay, I got it, and so forth? And then there's kind of the next step after that. Did the trainer approve or disapprove of the eventual change that was done? Or worst case scenario, did the trainer just simply have to take over from the trainee who's actually doing the operation. And then from all this, we were able to do a bunch of statistical analyses. For example, for same anatomic feedback that's provided, if the trainer bundles that anatomic feedback with some praise, it increased the chances that the trainee was going to change their behavior. So maybe that's all that it takes, is that our trainees need a little TLC, and that will encourage them to perhaps change their behavior. Now, this is just behavior observed in the live operating room. We have not done any kind of manipulation or interventions. This is simply observations. Really, what you'd have to do is you'd have to validate this in controlled environments, let's say in the training lab, where there are standardized tasks, and really the only thing you're manipulating or changing is the praise or the lack of praise, as an example. Lastly, I'll wrap this up in the next 3 minutes. This was just published this last month. This is looking at automating feedback, because this new grant, what it's going to do is, instead of 30 cases and those 3,700 lines of feedback, it's across 5 sites. We've proposed a collection of 500 cases, teaching cases from 5 different sites across the US, Cedars, Stanford, NYU, Temple, and I'm blanking on the last one. There's a 5th possible here. But the point is, we're going to collect 65,000 lines of feedback. Okay, so how on earth are we going to be able to process all that data? And again, this is, I'll skip through this pretty quickly, but this is the same model that I showed you earlier. You know, each line of feedback has a trigger, it has the feedback itself. How does the trainee respond to the feedback? Ideally, again, we want them to change their behavior. So if they were doing something wrong, they're going to hopefully do it a better job. And then ideally, the mentor at the end finally approves of the behavior. Okay. So this is, I'm sorry for the title, these are brand new slides. And so, you know, these are brand new slides I just added yesterday. But the idea is that by just the video and the transcripts, okay, we have now created this automated pipeline to group the feedback, mostly based on the audio that gets transcribed to text. And we're actually using GPT, ChatGPT, to group them based on similarities. Okay, so all the lines of feedback that have to do with affirmative feedback, meaning that they're saying, hey, good job, get grouped together. Anything that has anything to do with bleeding gets grouped together, and so forth. And then, but that's just the first step. You know, almost anybody can plug something into GPT. What actually matters the most is, what do you do with that information? So then we take what's in each of these clusters, and we then look at, is there a similarity in these groups? You know, for example, the bleeding one. Okay, if you look at the predictive nature of, if you happen to be in this cluster of information, what's similar about this? What we found was that anything that was placed in the handling bleeding group, there was a very disproportionate chance that the trainee was going to change their behavior. And that makes a lot of sense. If the trainer tells the trainee, hey, you need to handle this bleeding, there's some bleeding going on, you got to buzz it, you got to do something about it, there's a high chance that the trainee is going to actually change their behavior and actually fix the problem. And that's a good thing. So we've created this pipeline of taking a massive amount of transcripts from the operating room in these teaching cases to then predict, hey, what actually happens to this feedback. The goal for what we're trying to do is identifying the traits of feedback that is optimal because it is impactful. It changes what the trainees actually doing and guiding them in the right direction. Okay, let's see what else I have here. This is another slide from the same paper where we saw that certain things, while again, example was handling bleeding, that cluster of feedback about handling bleeding, while it was most predictive of a behavioral change, that same cluster actually ranks very low in terms of the likelihood it would lead to a verbal acknowledgement. And that makes sense also, right? If you are if you've been given feedback about handling bleeding, you're not going to just say, okay, you're going to do something about it, but you may not say okay at all. In contrast, something like a trainer's queries, they're asking a question. This is almost a sanity check. It just makes these things make sense that the trainee is going to respond to a question, right? So they're not going to act on it, but they are going to respond verbally, and that makes sense. Okay, and then this is simply just another way of looking at it. Different clusters of feedback. This just gives you a sense of kind of the words that are being used. Again, I like the bleeding example. So make sure this doesn't bleed, okay, or buzz that vessel. Be careful of the vessel, buzz it. You're going to make it bleed. Be careful. So these are some of the words that we've found in these clusters. And again, this part of it was done in an unsupervised manner, meaning that the models were simply looking for word similarities and putting them all together. Okay, so this is my last slide, take-home points. So we talked about how surgical assessment can be done through AI. And again, in our decades work, we've looked at it through kinematics, technical skills, surgical gestures. Notice how patient outcomes have been a part of almost every single one of these, because for me, it doesn't matter what these assessments are. If they're not grounded to how the patient does ultimately, it just doesn't matter. It doesn't have that. It doesn't have that clinical significance. And I gave you a brief glimpse into our work in optimizing surgical feedback, which will really complete that loop and allow us to improve performance. This is our group, and we have a fantastic multidisciplinary team of surgeons of many different backgrounds. We're excited to work with Ying and Grace, with you guys, Kenny Kim before he left. We work with general surgeons. We work with thoracic surgeons here at Cedars. So really, really excited to engage each and every one of you, because again, this is not a urological problem. This is not a general surgery problem. The things that I've discussed today really are things that all of us, I think, hopefully it resonates for all of us. So that's all I have, and I'm really excited to take any questions you may have.
Thank you, Dr. Hong. That was pretty incredible. I have the chat open. You guys can unmute and ask a question, or chat, post something in the chat if you have anything.
Hi, Andrew. This is Melissa Wong, one of the maternal fetal medicine docs, also with an AI interest. Super fantastic presentation, and incredible work really over the course of your career. My question is sort of related to, again, as you sort of alluded to, fast forwarding to this integration of surgical feedback. And what do you think, because sort of knowing from other disciplines, for example, in GI, and them adding in, the extra little windows to try to improve adenoma detection rates, and those having had kind of variable success in actually altering behavior. What do you think will be sort of the pieces that need to be integrated to really see behavior change from these augmented sort of decision support systems?
Yeah, thanks, Dr. Wong, for that question. I think it's multifold, right? If you break up, the ideal change of behavior to a assessment question, which is again my last 10 years of work, or the newer work in feedback, you're going to have challenges in both realms. You're going to have, just because an engineer can capture a data point doesn't mean that it's meaningful for a given clinical outcome. So in a lot of that work and a lot of our AI work, it is about associations. Even if you work with traditional stats, it's about associations. You see a signal, you see it tied to an outcome. Doesn't mean that they are a cause and effect, but at the very least, it's an association. So you got to start somewhere there. But then I think it's lost upon a lot of folks who don't quite understand that just because I can record how quickly, a surgeon performs a hysterectomy, for example, doesn't mean that that has a true impact on the eventual outcome. It could, it may not, but that's not guaranteed. And then secondly, it's on the delivery mechanism. Just because I know what's wrong with how a resident or trainee is operating doesn't mean that I can convey that message to them in a meaningful way for them to actually change their behavior. And so that's the rationale for our newer work is, okay, great, we're going to keep working on the assessment piece. One day, hopefully, we'll be really good at that. I think we are getting there. But, surgeons are a special breed of people. Not all surgeons are receptive to feedback. And so so there's a bit of human psychology or educational psychology mixed in there, and so we have an educational psychologist as part of our team in this newer grant, because we have to tap into that piece of it as well. So hopefully that answers your question. I think there are challenges on both ends. On the assessment part, are we looking at the right metrics, the clinically relevant metrics, but also how are we delivering that message back to the individual? And I think ultimately there will have to be some form of clinical trials where, we trial out that, hey, assuming you have the right metrics, are you able to get that message back to the operator and making sure that they can change their behavior?
Yeah, that definitely answers. Thank you. And I would just add in like another thing, not to layer AI on AI, but in a lot of ultrasound work, they've also integrated eye tracking into some of the sort of image recognition piece, and that I haven't seen that as much on the surgical side. That might be an interesting piece. Just sort of thinking about, how you were talking about sort of focusing on just the suturing parts with hand annotation. It might be another piece that would add an interesting layer.
Yeah, that's a great point. We bought these $30,000 eye trackers. This was when I was at USC, and that was the one thing that they wouldn't let me take to Cedars. That's okay; you can buy them for a lot cheaper now than $30,000. But we were looking at pupillary dilation as a marker of stress or cognitive workload. The challenge, and we dabbled in the gaze part of things, and there's definitely behavioral differences between more experienced or less experienced surgeons in relation to what are they looking at. More experienced surgeons are definitely very focused to the anatomy at hand versus less experienced surgeons. You can see their gaze just all over the map on a given screen. So that definitely can, if there's anybody interested, Dr. Wong, love to partner up, and that would add yet another piece to, this assessment of a surgeon.
So interesting. Thank you.
Any other questions?
Got some nice kudos in the chat. I think we're all soaking all this in. It's really incredible. I'll leave another minute or so if anyone else has a question or a comment. All right. Well, we can give you 6 minutes back of your day. Again, thank you so much. That was just really amazing work. Everybody stay safe and have a good day.
Thanks for having me.
Thank you so much.
Thank you.
Thank you.